So 27 is, you know how 25 and 24 kind of linked up together? One's about metabolism and the other one was about the GI and how we receive fluid and food. Here, 26 and 27 makes sense, right? 27 is about kidneys. 27 is about water content, fluid content. And then at the very end, right, acid base. Now, I do have a video just about acidosis, alkalosis, and I do have, and we'll go through it in the, towards the end. Just keep in mind though, right? A lot of what we're talking about in terms of body fluids, we've kind of discussed before. So let's talk about where we see fluid in the body. Where do we see fluid is 40% intracellular fluid. We call it the intracellular fluid compartment. Obviously, it's the fluid that's inside the cell. That's a fluid that's inside the 45 trillion cells in the body. Now, each cell is microscopic and very, very small, but when you multiply it by trillions, that becomes a great amount of water. 40% of our total body weight is intracellular fluid. Extracellular fluid is a fluid, there's two types, right? So if you think about a cell like simple cuboidal cell in the kidneys, well, that cell is not just by itself. It has a little bit of water external to it, especially in the proximal distal convoluted tubules, collecting duct. It's always surrounded by fluid called the interstitial fluid. Now, the best example of interstitial fluid I can give you guys is this, because it's hard to picture, right? Intracellular, it's easier to picture. It's inside the cell. Think of a water balloon. Extracellular fluid, specifically this one, there's two types of extracellular fluid space. Plasma is one of them. It's easy to see. It's found in blood, whole blood. It's a fluid component. Interstitial fluid, though, it's a little bit more difficult. Now, if you guys have gotten a scrape, a real bad scrape before, and then that little bit of yellow fluid leaks out, that's an interstitial fluid. That's the fluid that's found between your cells. And it has that salty, I know it sounds gross, right? Salty, yellowish color that we see sometimes when you put a Band-Aid on a cut and you see that yellow fluid come out, that's interstitial fluid. So that fluid, plasma, lymph, CSF, and synovial fluid forms our extracellular fluid compartment space. And it accounts for 20% of our body weight. So most of our body weight, 60% of our total body weight, is due to fluids found in these two main areas. Now, we will see, because of sodium-potassium pump ready, that there's going to be differences in amount of salts found in the intracellular versus extracellular. Again, what are we doing with the sodium-potassium pump? Taking sodium from the inside, pumping it out. So inside the cell, I'm going to have very low sodium. As sodium goes out, potassium goes in. So inside the cell, high potassium. So we're going to have that kind of difference that we've mentioned here. Now we're going to talk about numbers here. So in the intercellular fluid, 12. That's the amount of solutes, right? Milliequivalents per liter, milliosmoles right here. That's how much is inside the cell. In our interstitial fluids, 145. There's a 1,200% difference. Crazy. Plasma? Plasma really mirrors the interstitial fluid. Remember, right? They're laying right next to each other. So what happens is if you have a high amount of sodium in the interstitial fluid, we can expect it to be very similar in the plasma. What else? Sodium potassium pump. We're letting potassium in. Look at how much potassium we have. 150 inside the cell. Outside in the interstitial fluid, 4.1. Right? So we're talking about like a 3,000%, almost 4,000% difference here. Huge number difference. And then take a look at your plasma. Very similar. Right? So the plasma mirrors the interstitial fluid. Why? It's because they're very, very intricately linked to each other. Now, what else do we see? Chloride ions. Very high outside the cell, very low inside. Why? Chloride follows sodium more likely than potassium. So we pump out sodium, chlorine goes with it, right? And we'll talk about this one a lot. These two, bicarbonate and phosphate, they become very important for buffers. I know Stephen loves talking about buffers, right? So especially about biochemistry. So we'll talk about what they mean coming up. Hey, Stephen, let me see if you're muted.
Yeah, sorry, I was muted. What's up?
Right. Have you discussed at all, like some of the buffers and everything, biochemical buffers?
Yeah.
All right, so it should be in review, right?
Well, like I said, it's one of those things.
Regulation of body fluid concentration and volume. Content regulated, so total blood volume of water in the body remains constant. So we're gonna see, right? The main route at which we can keep, retain, or give out more water are the kidneys. If we need to, we can excrete water tremendously, as long as you pee, remember? You guys have probably had, I don't know, a few alcoholic beverages and start peeing for the next 5 hours once you started, right? That doesn't that suck, number one? My friend always makes fun of me because once I go, that's it, right? Every hour. But that's why the kidneys are a really good job at water excretion. It gets rid of excess water. And the best part is there are no kind of long-term effects for getting rid of it. So we're really good about it as long as you let yourself urinate. The problem again is when you don't get enough water. The kidneys can't make more water. Now, in terms of where do we get our fluid from? The biggest one is ingestion. Now we do see cellular metabolism producing water, but that's minimal amount. Remember, when we produce ATPs by glycolysis and the citric acid cycle and mitochondrial electron transport, one of the final byproducts is water and carbon dioxide. So what happens is water is produced, but what we're gonna see is most of that water and carbon dioxide will combine to form bicarbonate and carbonic acid. So you don't really see that cellular water because most of it is from that H2O and carbon dioxide. And when we transport it, we combine those two together to form carbonic acid. So even though we do have cellular metabolic water, most of that cellular metabolic water is trapped as carbonic acid because that water, H2O, and the carbon dioxide fuses together to form carbonic acid, and it becomes a really important buffer in our body, that carbonic acid. Osmolality versus osmolarity. Remember, I do not like using osmolality. The reason why is simple. Osmolality requires you to weigh it. So osmolarity is what we really use clinically, right? So osmolarity is solutes concentration per liter. By the way, when you do your training, hopefully, right? You guys will get in and then hopefully do the training pretty much soon, the clinicals. Well, yes. You guys have seen bags of saline before. Bags of saline tells you it's 1 liter bags, right? If it's 1 liter bags, why do you want to go out there and weigh it again? Because in osmolality is solutes per kilogram, right? So one is solutes per liter, the other is solutes per kilogram. Well, do you want, if somebody's like really requiring completely dehydrated, do you want to take that bag of saline and weigh it, find the scale? Not really. So especially when the bag already has liter on it. So medically we use this term. Now, it's almost used interchangeably though, right? In terms of both of them, it's a measure of water volume per solute concentration. The higher the solute concentration, the higher the osmolality / osmolarity. even though I can't spell.
It's
I
not
can't type.
right. I was just gonna say that.
My fingers aren't working either. All right,
Oh,
adding or
wow.
removing water changes the osmolality / osmolarity. You know what? From now on, I'm just going to remove osmolality.
Osmolality.
Right? Period. That's it. We're just going to use osmolarity. Right? Again, kind of makes sense, right? If you add more water to any solution, you're going to dilute it. The osmolarity then, right? What happens? If I add water, I increase the denominator, the lower number. So instead of 1 liter, now it becomes 2 liters on the bottom. Makes sense. The solutes, if we don't change it, well, it becomes less in terms of osmolarity here, diluting it. All right. So adding and remove water can either dilute it, adding water, or make it more concentrated, removing water. Increase osmolarity. Yeah, I'm gonna do this for everyone, guys. Increase osmolarity. Dang it. My brain is not working today. Actually, it is. My finger isn't working. All right. Increased osmolarity triggers thirst and ADH secretion. Makes sense. Why would we? When do we see increased osmolarity? When we are sweating a lot in a hot summer day, you're working out, you're walking, or you're gardening. Anything that you do during a hot day will increase the amount of sweat you release. Since sweat is predominantly water, you lose water more than even salt. As you lose that water, it goes first from your interstitial fluid space and then into your blood plasma state, right? So then you lose water from your bloodstream. What happens when we lose water from the bloodstream? We make it more concentrated, increasing its osmolarity. It makes sense then we activate thirst receptors and ADH secretion is increased. Remember, ADH is different. All it does is put water channels in, aquaporins, right? Because all you're doing is adding aquaporins, you don't need more salt to be reabsorbed for water to follow due to osmosis. And again, big picture, none of the ADH and aldosterone will increase your blood pressure. ADH will not decrease your osmolarity. It might keep it at that lower number, right? It might prevent it from getting even greater osmolarity, but it's not going to decrease it because that water that we secreted, that we are going to reabsorb, that water from ADH secretion, well, that water was already in our body. It's not like you're adding new water to it. The only way we can decrease osmolarity when we're dehydrated is to drink pure water. Drinking pure water is like putting water to any solution. Now our blood is that solution. And that blood we have, whole blood, has greater osmolarity because we're dehydrated. So if you put water in there, it makes sense. You can dilute it. This is one of the reasons why drinking cool water seems like the best thing in the world in a hot summer day. Why? Is because we will then drink that fluid, goes into our bloodstream, and now that's pure water, new water being introduced in your bloodstream. So you can then dilute the high osmolarity blood. Perfect. Now, keep in mind, I talked about dehydration. Anything. So I'm going to write this out right here, right? Shock. You guys have heard of shock before. Now, I used to have a lot more time, especially even like 2 semesters ago when we weren't in a lockdown. Shock is any drop in blood pressure, right? Any drop in blood pressure greater than 20% of your normal BP. Some books say 30, 35, but just understand that, right, from 25 to 35%. So anything that will decrease your blood pressure a lot is considered shock. So when you hear people going into shock, usually they're not going into shock, right? Now, the only time you might see it more often is when we have anaphylactic shock. Anaphylactic shock is you have an allergen, that causes widespread vasodilation because of widespread histamine release from the basophils. What happens if you completely vasodilate your blood vessels? You decrease the blood pressure. That's anaphylactic shock. You can also have shock due to dehydration, right? Hypovolemic shock. Hypovolemic shock means that you haven't had a drink of water in 3 days. And now, right, you're on the verge of death because it's so hot, you can't even sweat. You can't sweat because your body doesn't even want to lose water from sweating to cool you down. So it has this terrible conundrum where, what are we going to do, right? Our body heat's going to increase, yet we can't release water in the form of sweat to cool down because you just don't have enough water. We call that hypovolemic shock. That will cause a huge drop in blood pressure, greater than 25 to 35%. Now, the last type of shock, hemorrhagic shock. You guys have watched movies where somebody is, on the verge of death from being shot, stabbed, and they always say, right, in the movies, I just need some water. I just need some water, right? And the reason why is this. When you have shock, for whatever reason, whether it's due to hemorrhaging, if you cut your radial artery and now your blood is spilling out in massive pulses, what happens is that blood that exits will cause a drop in blood pressure. That's hemorrhagic shock. With hemorrhagic shock and any type of shock, we go and activate the brain, the hypothalamus, then will cause you to increase thirst receptors. So they feel the need to drink. The need to drink then will hopefully then increase the amount of blood volume, which will then normalize the blood pressure. But usually if you don't put a tourniquet on them, this thirst response is not going to be helpful. But due to any kind of drop in blood pressure, we can activate this response, right? Again, it's kind of weird that they mention it in the movies a lot, but yeah, that is something we really see in real life, is that when people get hemorrhagic shock, they have something that's very similar to what we see in people that are dehydrated. They have that increased thirst. They need water, right? And that's the only thing they want right then, is just water. So if we stop that bleeding, give them a tourniquet, and then give them water at first, hopefully we have saline to give them, and then give them whole blood, they can survive it. But yeah, that is one of the rare things that the movies and TVs get right, is that we do have that thirst response. Now, hormonal regulation of blood osmolarity. Again, I'm going to switch it. Osmolarity. Right? So remember how we look at this chart? Here's homeostasis, up and down. What happens when it comes too low? When it becomes too low, blood osmolality or osmolarity decreases. Usually, that's due to over drinking water. What happens when you have too much water? You start diluting your blood. When that happens, your blood osmolarity decreases. So we activate the control centers. Now we stop releasing ADH because we already have too much water volume, right? Our blood pressure might even be increased. So the last thing we want to do is release antidiuretic hormone and retain all that water when there's already too much. So what do? Instead, we inhibit ADH, inhibit our thirst receptors. So then we can go to the kidneys, and because we inhibited ADH, the collecting duct stops reabsorbing the water there. Because you stop reabsorbing the water in the distal convoluted tube and the collecting duct, we are then going to produce very watery urine. As we produce watery urine, I expel that excess water, and my osmolarity that was dropping because too much water, now I get rid of that water, and now it starts to increase towards normal. Perfect. Again, this area right here, the kidneys does a great job of, as long as you let yourself urinate. Now, how about up here? Blood osmolarity increases because you're dehydrated. Then we activate ADH secretion. We'll also have aldosterone being secreted, but they don't mention it here. So ADH secretion is released, is increased. then you activate more water reabsorption by water channels in the distal convoluted tubule and the collecting duct. And then you retain as much water as possible. Now, it says homeostasis here is restored. Keep in mind, the only thing that can make you go down towards normal is drinking pure water, right? This mechanism that will not allow you to go all the way to that normal set point. What it does do is lower it a little bit, and then it stays up here as a new normal, right? It doesn't come all the way down to that set point again. The only thing that will is to drink pure water. Right, ECF, extracellular fluid volume. ECF can increase or decrease even if osmolarity of extracellular fluid is maintained. Now, basically it's telling us that we can adjust the amount of fluid in the extracellular fluid space, even though we might have the same osmolarity. Carotid sinus and aortic arch baroreceptors monitor blood pressure. Juxtaglomerular apparatuses in the kidneys monitor pressure change. Receptor in the walls of atria and large vessel can respond to small changes in blood pressure. And this kind of mentions the regulation of blood volume and all the organs that are required. Remember, why is it so important to regulate blood volume? The big one is this: if your blood pressure drops too low, and your blood pressure is so low, you can't move blood out of the heart, you're gonna die from that. Or you can move it out, but it can't go into your brain because your blood pressure is so low. Well, you're not gonna perfuse your brain, so you're gonna die from that. So just keep that in mind, that all of these mechanisms to regulate blood volume are there to make sure you get enough blood flow. And if you don't pressurize your blood enough, you will not bring blood up against a force of gravity into the brain. And that's a big one, right? Because the brain and the head, the skull, those are only areas where you have to go against a force of gravity. Because of that, we need to pressurize it. Now here again, right, what happens when you have high blood volume and then high blood pressure? In the heart, ANH is released. In the kidneys, juxtaglomerular apparatus inhibit renin, right? Which without renin, you don't have angiotensinogen, you don't have aldosterone then. So all of these kind of work together, right? In the blood vessels, sympathetic division, detect increased blood volume, causes vasodilation of the kidneys, the renal arteries. So the more blood you have going into the kidneys, the greater the filtration rate. The greater the filtration rate, the greater the urine output. So there's always a direct relationship in the kidneys. If you ever get confused, just think about that. If you increase the blood flow to the kidneys, it means you're gonna increase the blood flow to the afferent arteriole, which increases your blood flow to the glomerulus. And anytime you increase blood flow in the glomerulus, you filter more. Your GFR increases, which increases your urine output. See how they are all directly related to each other? As one increases, they all increase. Same thing if one decreases as well. So if you have decreased blood flow, right here, then we'll have decreased blood going into the kidneys, then we'll filter less and produce less urine, retaining our new lowered blood volume. So then your blood pressure doesn't just dive off a cliff and it goes from like 100 over 60 till like 60 over 30, right? At that point here, when we have low blood volume and low blood pressure, what happens is we're just trying our best to keep the blood pressure at that lowered number to keep you alive. So all of this is meant to it's not gonna increase it tremendously, but once it goes down, it's able to stabilize it at a lowered number, right? And here, this good picture right here. Regulation of extracellular fluid volume. When you see a decreased blood pressure, renin is released from the kidney. Renin then activates angiotensinogen to angiotensin 1. Now, I'm just gonna write this part down a little bit more. angiotensin 1 then goes to the lungs and gets activated with ACE. Right? In the lungs, angiotensin 1 gets activated by angiotensin converting enzyme, which is an enzyme receptor which cleaves the last bit of amino acids, forming angiotensin 2, which is the more potent version, right? Angiotensin 2 then also stimulates aldosterone secretion, which will then hopefully increase water reabsorption by increasing sodium reabsorption. So we talked about ADH. ADH only puts water channels in, water and pure water only comes in. Aldosterone allows you to reabsorb water, but in order to do that, you have to reabsorb a lot of sodium. So will aldosterone decrease your blood osmolarity? No, because you have to reabsorb so much sodium before water then follows, right? So aldosterone doesn't decrease blood osmolarity. ADH does. Now, ACE are the same receptors that coronavirus attaches to, so then they gain entry into those cells. That's the reason why your lungs are so much more affected than other regions of the body. Now, we now know the heart could be affected as well. We do have ACE receptors in the heart. That is one way that the coronavirus enters the cardiomyocytes here. So this one, they talk about like the two similar hormones, right? Aldosterone and ANH, they work in opposition. This one now you have volume overload, where you have too much blood volume. Your blood pressure then is increased. Then ANH, atrial natriuretic hormone, is released from the right atrium, causes our kidneys to decrease sodium reabsorption. And instead, we excrete sodium from the cells, causing water loss, which is good because we need to get rid of that high blood pressure. Again, moderation, right? Drink anything and everything, but in moderation. Blood pressure as well. We want it to be low normal. Now, most of the time, it's really hard to get to low normal. Regulation of extracellular fluid osmolarity. These are the electrolytes, molecules, and or ions with an electrical charge. Again, electrolytes are usually our salts, right? Ingestion adds electrolytes to the body. Kidneys, liver, skin, lungs can remove it from the body. Concentration changes only when growing, gaining, or losing weight. In other words, our electrolyte levels should be pretty normalized based on our weight, our age right here. Sodium ions responsible, there's a big one right here. So highlight this one, right? Sodium, and I will have you guys just underline it, responsible for 90 to 95% of osmotic pressure. So most of the draw of water in one region to another is due to sodium. The more sodium in one region, the more water they'll move to that region. In terms of regulation of sodium, kidneys are the major route of excretion. We do lose a small amount in sweat, right? Insensible perspiration is water evaporation for the skin. Sensible is due to secretion of the sweat glands. Again, hypernatremia, you will hear that term. So important thing to know about this slide right here, right, that I would ask is this part right here, right? The one that I highlighted. Know what these terms are, right? Hypernatremia, elevated plasma sodium. Why? Well, Na, right? Hypo as in low. Anytime you hear the word hypo, think low, right? Hypotension, low blood pressure, right? Hyponatremia is low sodium. Again, Na. Right? In terms of intracellularly, Large organic molecules such as proteins cannot cross the plasma membrane. They're synthesized inside the cell and influences the concentration of solutes inside the cell. Sodium, potassium, and calcium, right, across the plasma membrane influences the concentration inside and outside the cell. Now the big one we're gonna see is the sodium-potassium pump, right? Because of the sodium-potassium pump, we're gonna pump out a lot of sodiums, 3 sodiums, but only 2 potassiums come back in. So with each cycle, you lose an extra positive charge. When you lose a positive charge from the inside, you become negative. So it's slightly negative inside the cell. Think of a skeletal muscle. Think of a neuron. All of our cells are slightly negative. The distribution of water inside and outside the cell is determined by osmosis. The solute concentration inside, solute concentration outside. That is the biggest draw for water and water distribution. Right. Next one, hypo and hyperkalemia. We'll talk about chloride ions, predominant anions. Magnesium, right, capacity of kidneys to reabsorb is limited. Excess is lost in urine. With magnesium, we know it's important for the heart functions. Now it's getting a little bit more play, become more important in the last few years, right? Because we know how important magnesium is for the normal cardiac functions. Potassium, though, is the biggest one. So I'm going to highlight, actually just underline this one. Right. So know this: potassium maintaining a narrow range, affects resting membrane potentials. Obviously, we talked about how your neurons and how your heart is going to contract when there's low and high potassium. So we kind of mentioned it before. When you have high potassium, your neurons are more likely to fire. Your cardiac muscles are more likely to fire. And then it goes into a supraventricular tachycardia. So it goes and it fires the muscles of the heart so often that your heart becomes tachycardic and, worst of all, arrhythmic, right? And that is the killing agent when we give people lethal injections, potassium chloride. Now, the weird thing is this part right here. Aldosterone increases the amount secreted, meaning, whoops, right? Meaning what? Meaning that whenever you see sodium that's reabsorbed, potassium is always released, right? Aldosterone increases sodium reabsorption inside the cells. Well, if you have a positive charge coming in, you need another positive charge going in the opposite direction. So when we reabsorb sodium with its positive charge, we are going to release potassium. As we release potassium, we do see people that are dehydrated and the potassium levels are abnormally low. That's why you might hear in the Grey's Anatomy, you might hear in the medical shows, right? That somebody has, dehydration and they have to give them, 1 liter of saline with a potassium rider. A potassium rider is just a little bit of potassium chloride that we hang with the saline. Why? Because we know that when you're dehydrated, you're going to produce a lot of aldosterone. In the process of producing the aldosterone and releasing it, your kidneys are going to reabsorb a lot of sodium, but at the cost of potassium being secreted. So then with that dehydration, potassium levels are also low. So when we do get it treated and you do go to the ER, they don't just give you a bottle of water and tell you to relax, right? Because we'd be pretty pissed if that happens. They give you saline, and if your potassium concentrations are low, they'll give you a potassium rider, right? Just an extra bag goes with the saline. Why? Because we know that if that potassium level goes really low, it's going to have a severe effect on your neurons and on your heart muscles. So here's all the different things about what ADH does, right? How does it get stimulated? What is its response? What is the result? Right? So don't be overwhelmed by this. It looks like a lot, right? But we've talked about it. What happens with ADH? How does it get activated? The ADH is the most important regulator of blood osmolarity. Well, it increases when you have increased blood osmolarity. Increased blood osmolarity usually is seen in dehydration. Remember, you sweat a lot when when you're in the hot sun. Sweat is predominantly water. So as you sweat out that water, you lose it from the bloodstream, causing our blood to increase in osmolarity. ADH is released from the posterior pituitary gland through its connection with the hypothalamus. So hypothalamus notices that increase in blood osmolarity. The hypothalamus causes the pituitary gland to secrete ADH. Now highlight the posterior pituitary, not anterior. Posterior pituitary. The effect is increased water channels, aquaporin 2s, right, in the distal convoluted tubule and the collecting duct, which then allows us to reabsorb pure water. That reabsorption of pure water will attempt to decrease the blood osmolarity because water will dilute the bloodstream right here, the blood, and hopefully decrease it. Again, usually the only thing that'll decrease it is drinking pure new water. Right? This is a good chart as well, and I'll probably have you highlight these. What happens when you have abnormally low or high sodium? Does it have effect? Right? High or low sodium, does it have an effect at all on your heart? Does it have an effect, direct effect at all on the actual rhythm of the heart and your neurons? No. Hyponatremia and hypernatremia affects water, right? Now, in terms of causes, this is very rare to have hyponatremia now, right? Usually we see this one, hyper. With hypo, the big thing, drop in blood pressure, right? When you have hyponatremia, usually your blood osmolarity decreases, right? Because it's decreased, your body thinks there's too much water. So it's gonna start urinating more volume, which then reduces the blood pressure. When the blood pressure is reduced, it leads to tachycardia, and then eventually decrease urine output. So both of these have a huge effect on blood volume, right? Hypernatremia, usually caused by high dietary sodium, but the high dietary sodium usually doesn't cause a massive amount of what we see here, right? Most of the time we see it from giving too much of this, making a mistake in giving somebody hypertonic solution of saline. And in some people, they have an oversecretion of aldosterone, which is pretty rare, right? When you have hypernatremia, it's like you're increasing the blood osmolarity. So your hypothalamus will increase our ADH secretion, right? And we have increased water volume because of the ADH, right? The ADH secreted means we, in the distal convoluted tubule and the kidneys, we are going to reabsorb pure water to attempt to normalize our blood osmolarity, right? When that happens, you will see so much water reabsorption that some people gain a little bit of weight, and there's a big one, you will see edema and elevated blood pressure, right? So here, kind of discuss potassium, and with potassium, again, potassium itself, we do not have a hormone that controls potassium directly. We do have a hormone that controls sodium, and that hormone that controls sodium always has an opposite effect on potassium. So let's think about what happens when we have, right, low, right, actually high blood potassium levels right here, goes up, and we don't have a hormone that directly works on potassium. So we have to use the one that has an indirect. So we have high levels of potassium, aldosterone's released. As aldosterone's released, we reabsorb sodium, but excrete potassium. By excreting the potassium, we get rid of the potassium, and then our potassium level starts to drop a little bit. So again, big picture, nothing directly affects potassium. Aldosterone is the only one, and AMH are the only ones that indirectly affects potassium. All right, so review this for potassium levels. What can cause hypokalemia? Alkalosis, which we'll talk about coming up. Insulin administration, right? Reduced potassium intake. And the effect with low potassium, bradycardia, atrioventricular block, decreased smooth muscle tone, delayed ventricular depolarization. All of these are bad, right? So all of these affect your muscles that can be excitable. And the big one is the heart. What happens when you eat too much? And usually we don't, I mean, you would have to eat a lot of bananas, like 20 bananas a day, every day, for you to get hyperkalemia, right? It's because people always ask me, is it from bananas? No, you'd have to eat so many of it, you'll be sick of bananas by the end of that day. And you'll never want to eat it again for the next couple of weeks. So usually it can be due to crush injuries. Remember, most of the potassium in our body is stored intracellularly. So the only way we see massive potassium levels is usually when people get crush injuries. They fall, right? Something falls on them. And now the skin cells, the cells of the organs gets crushed. As they get crushed, all the potassium that was inside leaks out, leading to hyperkalemia. And it leads to rapid cardiac repolarization, right? Muscle weakness, loss of muscle tone and paralysis, reduced rate of cardiac action potential conduction, right? So yeah, it can cause death from that. Calcium, vitamin D, calcitonin, right? So PTH increases calcium extracellularly, decreases extracellular phosphate levels as well, right? Vitamin D stimulates calcium uptake, calcitonin decreases extracellular calcium levels. Now with calcium, keep in mind with calcium, calcium has an indirect role on our ability to depolarize, right? High calcium will, right, so decreased levels leads to spontaneous action potential. So high calcium prevents membrane depolarization. How it does that is this. I think we mentioned it last semester, right? When you have high calcium, it's going to increase decrease our threshold to trigger an action potential. Normally, to trigger an action potential, you need to hit minus 55 millivolts, right? That's a threshold. When you have too much calcium, the threshold is then going to be increased towards 0, right? Making it harder to depolarize. So over here, these are all the different symptoms as well. I'm not gonna ask about all these symptoms. I would ask about, plasma. I don't know what's wrong with my spelling. I will ask about generalities, right? What happens with high potassium? What happens with low? So know a couple of these, and I usually will have at least 1 or 2 of the symptoms so you can tell which one is which. I wouldn't just have, just intestinal cramping. I'd have like a whole series of this. So then you can kind of find out maybe one of them makes sense to you.
Okay.
Right. Now, the last thing I want to talk about is acid bases. All right, acids, bases. Most of the time, everybody hates acid and bases, right? You know what? Let's take a little break first.
Yeah.
Let's take a little break first, and then we come back in 5 minutes. We'll talk about acid and bases.